Hi, this is Mitral. We discuss a case with multiple disease, severe calcification, 2 chronic total occlusions, and moderate mitral regurgitation in a case. And we discuss how to revascularize this patient. This is 70 years old man with previous myocardial infarction, probably from circumflex artery. There are heart failure symptoms at admittance. After coronary angiography, coronary bypass surgery and mitral valve surgery was advised to this patient. But we re-evaluated the patient and we found that mitral regurgitation is not severe. We just follow mitral regurgitation, and circumflex chronic total occlusion PCI is not required in this patient because of no viable tissue in the circumflex territory, and LAD was the only open artery. Because of that, we first plan PCI for the RCA CTO. AL1 guiding catheter was used. This is left coronary angiogram, another chronic total occlusion in the circumflex artery, but there is no viable tissue in this territory. There is significant lesion in the LAD with severe calcification. This was only open artery. This is PT2 hydrophilic guide wire. Wire delivery is not easy, and this is balloon, 1.2 mm CTO balloon, but delivery is not possible at the beginning. And we used catheter extension, and we succeeded to deliver balloon, but after ballooning, distal vessel caliber was very small. We decided to continue CTO PCI at another session at this moment. Investment PCI was performed for the RCA at this moment. There was a linear dissection in this area. Because of that, we put a stent, long stent, and we left RCA at this position. LAD was the only open artery with severe calcification. This was a balloon undilatable lesion at this point, and at this point, and we succeeded to dilate the lesion. Lesion preparation is very important for the calcific lesion, but balloon delivery was not possible for this non-complete balloon, and we used coaxial anchor technique. We dilated the balloon and pushed catheter extension, and then fully dilate calcific lesion. By the help of coaxial anchoring, we cannot see at this picture, but we delivered catheter extension at this point because we could not succeed to deliver this stent to proper position. We first deliver catheter extension and then stent, and we pull back catheter extension and dilate the stent. After dilatation, this was 2 years later picture of the LAD. Stent was patent. There was no intimal hyperplasia or minimal intimal hyperplasia in this patient. Circumflex territory was not viable, and this is the investment PCI. 2 years later, long investment because of COVID-19 pandemic, and you see linear dissection at this area, and distal vessel caliber was dilated. With respect to previous pictures. Unfortunately, we couldn't succeed to deliver 1.2 balloon at this point, crux area. We have done 2 granuloplasty at this point, 1.2 and 1.5 balloon was ruptured, intentionally ruptured at this area, and then 2.012 balloon was delivered after 2 granuloplasty. This is coaxial anchoring technique. After dilatation of the balloon, we pushed catheter extension because delivering of the equipment was not successful with JR4 guiding catheter. After introducing catheter extension at this point, we push the stent and then we pull back the guiding catheter. You cannot see this because performed under fluoroscopy. This area was the point of resistance. We couldn't push the stent from this point. Lesion was predilated with 2.75 NC balloon before delivering the stent. And this is the final picture of the RCA after post-dilatation with 2.75 mm balloon. You can see calcification and stent. This picture, this is like a heart growing. You see the extension of the calcification. This is the end of my slide. In conclusion, in the CTO PCI, we should think about vasodilatation related PCI related vasodilatation in the CTO lesion. We could avoid full stenting of the CTO area or full dilatation of the vessel. We just leave the CTO. We just perform CTO PCI and leave the beyond vessel alone. And it will dilate by the time, as you can see in this patient. And at the beginning there were two CTO lesion and one calcific LAD lesion. It was the only open artery, but we did not perform circumflex CTO because there was no viable tissue in the circumflex territory, and the lesion became less complex in this case. One CTO and one calcific LAD lesion. And after these PCIs, patient symptoms relieved. There was no heart failure, and functional capacity was class 1, especially after second investment PCI, CTO PCI for the RCA. Thank you very much.